1, 2,
And maybe a female.
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of like clinical precision.
Right, exactly.
It feels almost like engineering, you know, like you break your arm, the x-ray shows that jagged white line on the bone, and the doctor just points at it and says, ah, there it is, that's the problem.
Yeah, it's very binary, very objective.
Broken or not broken. I mean, it's clean, and honestly, it's comforting. We like things to be visible. But then you stepped into the world of psychiatric nursing.
Oh, yeah. That's a whole different ballgame.
Right. You walk onto an inpatient behavioral health unit, and suddenly that x-ray machine is just, well, it's broken. We are looking at a diagnostic landscape that is entirely invisible to the naked eye. It's murky.
It is, honestly, the absolute definition of diagnostic muddy waters. And for the dedicated nursing students or clinical practitioners listening to us right now, you know who you are. That murkiness can feel incredibly intimidating.
Whoa, absolutely paralyzing.
Exactly, because when you are standing at the bedside of a patient in profound distress, or, you know, when you're sitting down to take your board exams, the sheer volume of psychiatric variables can just freeze you in your tracks.
Which brings us to our mission today for this deep dive. We are taking this massive stack of clinical guidelines and we are boiling it down.
We're using the 80-20 rule today.
Yes. The 80-20 rule. We want to teach you the 20% of the material that will give you 80% of the understanding you need to just absolutely crush those NCLEX style questions. And more importantly, deliver incredibly safe patient care.
Because safety is everything in this field.
It really is. And to start, we need to unpack this incredibly dangerous paradox right away. It's a clinical reality that seems, well, completely backward to human logic.
It really does.
It's this idea that the exact moment a severely depressed patient starts feeling a little bit better, that is actually the most lethal time for them.
Yeah.
Why is the onset of recovery like the highest point of danger?
That is the ultimate question in psychiatric nursing. And it is entirely counterintuitive. I mean, understanding the mechanism behind that paradox is the master key to patient safety.
So what's actually happening there?
It has to do with the pharmacokinetics of our treatments. So antidepressants take anywhere from 4 to 6 weeks to actually lift a patient's mood, to change the neurochemistry enough to alleviate the despair.
Okay, 4 to 6 weeks. That's a long time.
It is. But they often provide a quick boost in physical energy much sooner, sometimes within a week.
Oh, wow. So you have a patient who is still entirely like enveloped in the psychological darkness of wanting to die, but now because of the medication, they suddenly have the physical energy to get out of bed and execute a plan.
Precisely. That energy burst creates a highly lethal, invisible window. Because before the medication, the patient might have had suicidal ideation, sure, but they were suffering from such profound psychomotor retardation.
Just a crushing lack of energy.
Exactly. Such a lack of physical energy that they literally couldn't act on it. So, in a way, the intervention temporarily creates the emergency.
The intervention creates the emergency. I mean, that is a massive paradigm shift.
It really is. And to navigate that, you have to build a mental architecture of the two opposing poles of human experience. We're talking about major depressive disorder, or MDD, and bipolar disorder.
Let's lay those out.
Think of MDD as a systemic shutdown. It is characterized by anergy, which is a pervasive, crushing lack of physical energy, and it's accompanied by anhedonia.
And anhedonia is the inability to feel pleasure.
Right. It's the complete neurological inability to experience pleasure. The internal engine is just seized up. But then on the complete opposite end of the spectrum, you have bipolar I disorder, defined by acute mania.
So the engine is running too hot.
Exactly. It's a high-speed, high-risk state of extreme psychomotor agitation. The neurological engine is completely redlining.
Anergia versus mania. The system seizing up versus the system tearing itself apart from, like, over-revving. And to treat these extreme states, we use powerful biological tools, meaning medications.
Powerful and dangerous.
Right. Because as we just discussed with that antidepressant energy burst, these tools are double-edged swords. So looking at the clinical guidelines, there are really a big three when it comes to medication traps that every practitioner needs branded into their brain.
Let's list them. First, you have your SSRIs, selective serotonin reuptake inhibitors. They are the safe frontline go-to for depression. But the hidden trapdoor there is serotonin syndrome.
Which we'll get into the physiology of later, how that basically cooks the nervous system.
Yes, we will. Second is lithium. This is the gold standard mood stabilizer for bipolar disorder, but it is fundamentally a salt.
So it's heavily dependent on hydration.
Exactly. Its toxicity is entirely dependent on the patient's fluid and sodium balance. And third, the MAOIs. These are older, highly effective antidepressants that come with a massive dietary trap.
The tyramine crisis.
Right, the tyramine-induced hypertensive crisis.
So if I'm studying for my boards or, prepping to take a patient assignment, I shouldn't just be memorizing a laundry list of disease symptoms.
Oh, definitely not.
The clinical logic requires me to actively look for the hidden danger in the treatment itself.
That is the core of clinical judgment right there. In psychiatric nursing, your job isn't merely to administer the treatment. The primary job is to anticipate, recognize, and manage the lethal side effects of that treatment.
Wow.
You have to assume that the cure is almost as dangerous as the disease until proven otherwise.
That reframes everything. It's not just about treating the pathology, it's about surviving the pharmacology.
Precisely.
Well, let's look closer at that pathology, starting with the systemic shutdown, major depressive disorder. So the clinical criteria require at least 2 weeks of a depressed mood or loss of interest.
Plus a cluster of other symptoms.
Right, like weight fluctuations, sleep disturbances, intense fatigue. But why specifically 2 weeks? Like, what is happening in the brain during that time?
Well, the 2-week time frame is critical to differentiate MDD from transient sadness or acute grief, which, are normal human experiences.
Sure.
When we look at the pathophysiology of a true MDD episode, we are looking at a sustained neurochemical deficit, specifically deficits in monoamine neurotransmitters, serotonin, norepinephrine, and often dopamine.
And what do those do exactly?
Serotonin regulates mood, sleep, appetite, and even pain perception. Norepinephrine drives energy, focus, and alertness. Dopamine controls the reward and pleasure centers.
So when all of those drop,
When these are globally depleted for over 14 days, the neural pathways actually begin to change.
it's like the brain's internal messaging app is down and the stress alarm gets stuck in the on position because we also see in the data that cortisol, the primary stress hormone, and systemic inflammatory markers are chronically elevated in these patients.
That's a highly accurate analogy. The messaging app is down, and the hardware itself is overheating. There's an ongoing, really fascinating debate in the neurobiological research about causality here.
Like what causes what?
Exactly. Does chronic psychological stress cause the elevated cortisol, which then triggers neuroinflammation? Or does a baseline state of inflammation cause the elevated cortisol, which then breaks down the neurotransmitters?
It's a chicken and egg situation.
It is, but either way, the brain is in a state of severe, measurable biological distress. Over time, chronic high cortisol is actually neurotoxic. It can cause the hippocampus, the area of the brain responsible for memory and emotion regulation, to physically shrink.
Wait, physically shrink. That is wild, which totally explains why this is so much more than just feeling sad.
Right.
So who is most at risk for this neurochemical failure? We know genetics play a massive role, but it's not just like a simple DNA lottery. The data shows that having a first-degree relative with major depression increases your risk by 2 to 3 times.
Yeah, that brings the risk up to a 20 to 30% chance compared to about 10% in the general population. Twin studies confirm this, showing a 40 to 50% heritability rate.
But the environment matters too.
Oh, absolutely. Biology loads the gun, but the environment pulls the trigger. The social determinants of health are profound here. Being divorced, separated, or widowed, and lacking a strong interpersonal support network significantly elevates the risk.
Isolation.
Yes, isolation is a potent catalyst for systemic inflammation and depression.
Okay, let's translate this into the clinical reality. If you walk into a patient's room, what do you actually see and hear? We mentioned anergia and anhedonia, but there are behavioral findings that are just, deeply disturbing to witness.
Like rumination.
Right, rumination, this relentless, agonizing looping of negative thoughts. And then there is latency of response. I feel like students often read that term in a textbook, but experiencing it in the room is entirely different.
Latency of response is profound. You pull up a chair, sit down, and ask the patient a seemingly simple question. Like, how did you sleep last night, John?
And then
And you wait.
attenuate.
10 seconds, 20 seconds. It can take up to 30 or 40 seconds for them to formulate an answer.
40 seconds of silence.
Yes. Their cognitive processing, their very ability to retrieve vocabulary and move their vocal cords is bogged down in extreme slow motion.
And I think the instinct for a new nurse is to jump in, to say, did you sleep okay? Was it the noise? Are you in pain?
Yes, the instinct is to fill the silence, which is actually the worst thing you can do. It rushes them, it highlights their cognitive failure, and it leads to intense frustration for both of you.
So you just have to wait.
You have to learn to sit comfortably in that heavy silence and give their brain the time it needs to fire those sluggish synapses.
We call that physical and mental slow motion psychomotor retardation. But counterintuitively, severe depression can also manifest as psychomotor agitation, right? Like pacing, wringing the hands, picking at the skin.
Absolutely. The internal distress is so high that it bleeds out into physical restlessness. It is an incredibly agonizing state because they have no mental energy to do anything productive, but their body cannot sit still.
It sounds like torture.
It is. And while we are talking about extreme manifestations, we must highlight a major safety concern here.
Psychosis. This is a crucial point for clinical judgment. I see nursing students conflate psychosis strictly with schizophrenia all the time, like assuming that if a patient is hallucinating, they must be schizophrenic.
Right, but severe MDD can absolutely feature psychosis. 10 to 20% of patients with severe depression experience psychotic features, delusions, and hallucinations.
But there's a difference in how it presents, right?
The key distinction is that in major depression, the psychosis is almost always mood congruent.
Meaning the hallucinations match the profound despair.
Exactly. They aren't experiencing bizarre sci-fi delusions about alien microchips like you might see in schizophrenia. A severely depressed patient might genuinely believe they are personally responsible for a recent natural disaster.
Oh, wow.
Or they might have command hallucinations. A relentless, disembodied voice literally telling them that they are worthless and need to end their life.
Which obviously drastically escalates the immediate suicide risk.
Tremendously.
Which brings us to the absolute priority nursing assessment. All the clinical guidelines agree on this. The first assessment upon admission and continuously throughout the stay is suicide risk. And you can't tiptoe around it.
You cannot hint at it.
Yeah.
You cannot ask, are you having thoughts of harming yourself?
Mm-hmm.
Because harm is vague. They might think, no, I don't want to cut my arm. I want to die.
Right.
You must look them directly in the eye, use a calm, matter-of-fact tone, and ask, are you thinking about killing yourself?
Mm-hmm.
Or are you experiencing suicidal thoughts?
I know new nurses are terrified to ask this so bluntly. There's this lingering myth that if you say the word suicide, you're going to plant the idea in their head.
We need to aggressively tear down that myth right now. You cannot plant the idea of suicide into the mind of a non-suicidal person just by asking a clinical question.
Right.
If they're suicidal, they already have the idea. It is already dominating their internal monologue. In fact, research shows that asking directly actually brings an immense sense of relief to the patient.
Relief.
Yes. They are trapped in a terrifying, isolating echo chamber. When a clinician asks directly, without flinching, it signals to the patient, I see how much pain you are in, and I am not afraid of it. It is profoundly validating.
Validating that pain leads us right into interventions, because when someone is deeply entrenched in that level of depression, basic activities of daily living ADLs like showering or putting on clothes, they feel like climbing Mount Everest.
The executive function of the brain is completely offline.
So how do we help them without doing everything for them?
The strategy is breaking tasks down into micro steps. If you walk into a room and ask a severely depressed patient, do you want to get dressed and go to group therapy? That is a massive global task.
It's too much.
It requires sequencing, decision-making, and physical exertion.
Right.
Their overloaded brain will likely just reject it, and they will say no or just stare at the wall.
So you remove the decision-making burden entirely.
Yes. You provide the executive function that their brain is currently lacking. You don't ask a yes or no question. You say, John, it is time to get dressed for the day. Here are your gray slacks. Please put them on.
Here are your gray slacks. Put them on. You know, to an outsider, that might sound almost bossy or overly authoritative.
I know it does, but physiologically, it's a lifeline. It is therapeutic structure. You have narrowed their universe down to one single manageable action, putting one leg into a pair of pants.
And what if they still can't do it?
If they still can't do it because the psychomotor retardation is so severe, then you step in and say, let me help you with your slacks. But you always give them the opportunity to complete the micro step themselves first, to prevent learned helplessness.
Let's circle back to that terrifying paradox we opened with, the antidepressant energy burst. We know we are looking for a sudden shift in behavior.
Right. If a patient who has been deeply depressed, barely moving, isolating in their room for a week, suddenly appears cheerful, expresses intense relief, or starts giving away highly valued personal belongings, that is a blaring neon red alarm.
It's such a tragic clinical irony. Like, the family comes to visit on a Sunday, sees the patient smiling, sees them engaged, and they pull the nurse aside and say, "Oh, thank God, the new medication is finally working. We have our son back."
It's heartbreaking.
But the experienced psychiatric nurse looks at that exact same smile, and their blood runs cold.
Because the nurse knows the pathophysiology. The medication hasn't cured the depression in 7 days. What has likely happened is that the patient has made the final concrete decision to die.
The agony of ambivalence is over.
Exactly. The back and forth struggle of should I live or should I die is over. Making the decision brings a rush of profound, terrifying psychological relief.
And then combine that artificial relief with the slight physiological energy burst from a newly prescribed SSRI.
And they finally possess the physical capacity to carry out a lethal plan.
That is exactly why clinical judgment requires us to increase our vigilance, perhaps initiating one-to-one observation precisely when the patient looks like they're getting better.
Always.
Let's talk about therapeutic communication, because this is another area where standard human instinct completely fails us. When a patient expresses that deep existential despair, saying they are worthless, the guidelines suggest the best response is often active listening and offering self. Just sitting in silence.
Your physical presence is reality. It is a grounding mechanism. Saying, I'm going to sit here with you for 15 minutes, communicates that they are worthy of someone's time, even when their own brain is telling them they are a burden.
I'm going to push back on this a little because sitting in silence goes against every fiber of a nurse's being.
Oh, I know.
Nurses are fixers. We titrate drips. We bandage wounds. We solve problems. If someone is crying in psychological agony, my overwhelming instinct is to reach out and say, it's going to be okay. Things will get better. The medicine will work.
And that is the instinct of a compassionate human being. But in psychiatric nursing, it is the wrong intervention.
Really? The wrong intervention?
Yes. When you offer platitudes like, things will get better, or look on the bright side, you are completely invalidating their current reality. You are inadvertently signaling that their pain isn't justified, or worse, that you are uncomfortable with their pain and want them to stop expressing it.
Or when well-meaning family members say, but your children need you.
That is arguably the most destructive thing you can say.
How so?
A depressed patient already feels like a toxic burden. Reminding them of their family amplifies their inappropriate guilt. Their diseased neurochemistry translates that into, you're right, my kids need a functioning parent. I am fundamentally broken and incapable of being that parent. Therefore, they would actually be better off without me.
Wow, I never thought of it that way.
Never try to fix a depressed patient's cognitive distortions with logic or forced cheerfulness. You sit with them in the dark until they're ready to walk out of it.
That is profound. Okay, to summarize the clinical judgment and exam logic for MDD, the priority action is relentlessly assessing suicide lethality. The first nursing intervention for communication is offering, literally just sitting with them and using broad openings like, tell me what that feels like for you.
Spot on. That's the core of it.
Now let's dramatically shift the clinical picture. We are moving from the slow, agonizing depths of MDD to the hyperkinetic, dangerous heights of bipolar mania. The transition between these two states can be whiplash-inducing.
If major depressive disorder is a total lack of energy, mania is an uncontained explosion of it.
So what are the actual diagnostic criteria?
To meet the clinical criteria for bipolar I disorder, the patient must experience a distinct period of at least 1 week of abnormally and persistently elevated expansive or irritable mood, paired with abnormally increased goal-directed activity or energy.
And it has to be severe enough to cause marked impairment in social or occupational functioning or necessitate hospitalization to prevent harm.
Right. Contrast that with hypomania, which we see in bipolar II disorder.
Hypomania is the milder cousin. The diagnostic time frame is only 4 days, not a full week. Crucially, hypomania does not severely impair the patient's functioning, and it never features psychosis.
In fact, many people in a hypomanic state feel incredible. They are highly productive, charismatic, and need less sleep.
So they probably don't even want treatment.
Because it feels so good, they rarely seek treatment during a hypomanic phase, It's only when they inevitably crash into a severe depressive episode that they present to the clinic.
Let's look at the pathophysiology of true acute mania. We mentioned the monoamines being depleted in depression. Here, we see the opposite.
We see a surge, increased levels of catecholamines, dopamine, and norepinephrine. The brain's filtration system, the reticular activating system, is essentially short-circuiting.
What does that mean for the patient?
It means every sound, every color, every thought is processed with equal intense importance. They're bombarded by internal and external stimuli and cannot filter any of it out.
The risk factors are interesting to note here. Bipolar disorder affects men and women almost equally, which differs from MDD, where females are diagnosed at nearly twice the rate of males.
True.
And there is a massive comorbidity with substance use disorders, particularly alcohol.
That comorbidity is a vital clinical insight. Why do they drink? Often it begins as profound self-medication.
To slow down the brain.
Exactly. Alcohol is a central nervous system depressant. If your brain is running at 200 miles an hour and you can't turn off the racing thoughts, a bottle of vodka slows the engine down enough to allow for a few hours of sleep.
But obviously that causes other issues.
Huge issues. If you don't treat the alcohol use disorder alongside the bipolar disorder in the clinical setting, the mood instability will persist. The alcohol destabilizes the very neural pathways we are trying to heal. You have to address both concurrently.
So what does a manic episode actually look like when you were standing in the room? The subjective and objective findings. We hear a lot about pressured speech. What is the physiological reality of that?
Pressured speech is unrelenting, rapid fire, loud talking. It feels like a physical force hitting you. They don't pause for breath. They don't pick up on your nonverbal cues like you raising your hand or opening your mouth that indicate you want to speak.
And if you do interrupt,
If you manage to interrupt them, they might become fiercely irritable, or they might just start their entire monologue over from the very beginning. The speech is being driven by the sheer pressure of their racing thoughts.
the guidelines also describe flight of ideas, where they jump from one unconnected thought to another.
Right. They might be talking about the color of the paint on the wall, and suddenly they're explaining a multi-million-dollar business invention, and then they're talking about a memory from 3rd grade.
And behaviorally,
Extreme, uncontainable hyperactivity. They might present wearing bizarre, highly flamboyant, or sexually suggestive clothing with excessive makeup. They invade personal space constantly because they have zero concept of boundaries.
because their grandiosity tells them everyone wants to be near them.
Exactly. And they engage in extreme risk-taking behaviors, maxing out credit cards on, buying sprees they can't afford, handing out their life savings to strangers, or engaging in hypersexual behavior without any regard for consequences.
Which brings us to the safety concerns. We often think of suicide or violence as the main risks in psychiatry, and those are absolutely present in bipolar disorder, especially when mania crashes into depression. But in acute mania, the most immediate threat to life is actually physiological.
Yes. You are assessing for physical exhaustion and cardiovascular collapse.
Because they just don't stop.
Right. A manic patient might go 4, 5, or 6 days without a single minute of sleep, and they genuinely do not feel tired. Furthermore, they face starvation and severe dehydration because they are quite literally too busy to stop and eat a meal.
And the body can't handle that.
The human body is a machine, and it is not designed to run at max RPMs for a week straight without fuel or rest. Eventually, the heart will simply give out.
So, as a nurse, how do you intervene? How do you feed someone who refuses to sit in a chair for more than 3 seconds? This brings us to one of my favorite, most practical nursing interventions from the guidelines: finger foods.
It is a classic clinical judgment scenario and a real-world lifesaver. You cannot give a manic patient a plate of spaghetti, a bowl of soup, or a steak that requires cutting.
It's just too much work.
It requires too much focus, and they won't sit down long enough to eat it. You must provide high-calorie, high-protein finger foods that they can eat while they are pacing the hallway.
And the distinction is important. You don't hand them a stick of celery.
Absolutely not. Celery has negative calories. You are trying to prevent cardiovascular collapse from starvation. You hand them a peanut butter sandwich, a protein bar, chicken nuggets, or a fortified protein shake in a cup with a lid. Nutrition on the run.
I love that. Nutrition on the one. What about milieu management? How do you control the environment when the patient is out of control?
You must aggressively decrease environmental stimuli. Dim the lights, turn off the loud television in the day room, and remove them from chaotic group settings. A quiet, low-stimulus room is essential.
And what if they resist?
You must avoid power struggles. You cannot use logic to argue a manic patient out of a delusion, and if you try to rigidly enforce a minor rule, you will trigger severe irritability and potentially physical aggression.
But they possess all this kinetic energy. You can't just forcefully strap them to a bed, right?
Right.
That violates every principle of the least restrictive environment.
Exactly. The least restrictive, most effective intervention is to channel that massive physical energy into non-competitive, large motor activities.
Like what?
If a patient is pacing wildly and invading other patients' space, you don't yell at them to sit down. You redirect the energy. You say, John, I have a big job and I need your help. Come sweep the hallway with me. Or help me arrange these heavy chairs in a circle.
That makes total sense.
You provide a safe, physically exhausting outlet that doesn't require complex concentration.
That is brilliant redirection. Let's look at the safety red flags for mania. The mood is incredibly labile, right?
Extreme alacrity. A patient might be euphoric 1 second, laughing and telling you that you are the most beautiful, wonderful nurse they have ever met. But the moment you set a necessary limit, like telling them they cannot use the unit phone to call the president at 3:00 a.m., that euphoria instantly snaps into intense hostility, verbal abuse, or physical aggression.
So how do you communicate therapeutically in the face of that?
You use short, simple, concise sentences. Their attention span is shattered. You don't give a 3-part instruction. You might need to use a calm, firm tone and say, please speak more slowly. I'm having trouble following you.
Notice you put the burden of understanding on yourself, not them.
Exactly. It de-escalates the tension.
And for boundary setting, because
Yeah.
they will push every single boundary.
Matter of fact, limit setting is crucial. John, you are too close to my face. Please stand back 2 feet. You identify the unacceptable behavior clearly, and you state the expected behavior simply.
Just clear and direct.
And crucially, this is vital for their long-term recovery. You do not shame them for their bizarre, intrusive, or hypersexual behavior.
Right, because the pathophysiology is driving the behavior. And when the mania eventually breaks and they crash into the depressive phase, they often experience crushing, suicidal shame over what they did when they were manic.
Exactly. They remember alienating their family or stripping off their clothes in the hallway. It is your job as the nurse to protect their dignity when they cannot protect it themselves.
So how do you handle it in the moment?
When they are inappropriate, you use matter-of-fact redirection. Let's go to your room and find a sweater. You are holding their dignity and trust for when they cycle back to a state of normalcy.
Holding their dignity and trust. That's a beautiful way to phrase that. So, summarizing the clinical logic for bipolar mania. The priority dietary intervention is high-calorie finger foods. The priority milieu intervention is decreasing stimuli, and the priority behavioral intervention is redirecting excessive motor activity to safe, non-competitive tasks, always choosing the least restrictive option before considering chemical or physical restraints.
Perfect summary. You nailed it.
All right, we have mapped out the pathology. Now it is time to plunge into the pharmacology. To treat these massive neurochemical shifts to repair the broken messaging app or slow down the redlining engine, we deploy heavy-hitting medications. But as we've established, these drugs are essentially controlled poisons.
They alter the fundamental chemistry of the central nervous system. Let's start with the frontline treatments for depression, the SSRIs and SNRIs. Drugs like Fluoxetine, Sertraline, citalopram, and venlafaxine.
The mechanism of action here is right in the name. Selective serotonin reuptake inhibitors. Normally, after serotonin is released into the synaptic cleft to transmit a signal, it gets sucked back up, reuptaken by the original neuron. These drugs block that vacuum process. They force the serotonin to linger longer in the synapse, enhancing the signal.
Right.
So why are these considered the absolute first-line treatment over older drugs? Is it just because they work better?
Interestingly, they don't necessarily work better in terms of overall efficacy compared to older drugs.
Yeah.
They are first line purely because of their safety profile.
Safety, again.
Always safety.
Yep.
Older antidepressants carry massive anticholinergic side effects. Dry mouth, blurred vision, urinary retention, profound constipation, and significant cardiac toxicity. SSRIs have a much cleaner receptor profile, making them vastly safer, especially for older adults. But the paramount reason they are first line is their safety in overdose.
Because we were treating a population with an inherently high risk of suicide.
Exactly. It is incredibly difficult to achieve a fatal overdose by taking a bottle of Sertraline. It will make you violently ill, but it rarely stops the heart. That safety margin is why they are the go-to. However, the hidden trapdoor with SSRIs is serotonin syndrome.
Let's explain the physiology of serotonin syndrome. Serotonin isn't just a happy chemical in the brain. It exists all over the body. It regulates gut motility, blood vessel tone, and muscle contraction. So what happens when we trap too much of it in the synapses?
The entire nervous system becomes dangerously hyperstimulated. You see a triad of abnormalities: cognitive changes, autonomic instability, and neuromuscular hyperactivity.
What does that look like?
The patient becomes acutely confused or agitated. Their autonomic nervous system goes haywire, leading to hyperthermia temperatures, spiking dangerously high tachycardia, and diaphoresis, which is profuse sweating.
And the neuromuscular symptoms are the most visually alarming.
Yes, you see muscle rigidity, hyperreflexia, which means overactive reflexes, and clonus, which is an involuntary rhythmic muscle contraction. The patient's body essentially starts vibrating and stiffening. If not recognized and treated immediately, usually by stopping the offending agents and administering serotonin antagonists like cyproheptadine, it can progress to seizures, coma, and death.
Which perfectly transitions us to the older, much more dangerous medications, the TCAs, or tricyclic antidepressants, drugs like amitriptyline and imipramine. They block the reuptake of serotonin and norepinephrine, but they are messy. They block a bunch of other receptors, too.
They are very messy. They block histamine receptors, causing sedation and weight gain. They block muscarinic receptors, causing those severe anticholinergic effects we mentioned. But the most critical factor is that they block sodium channels in the heart.
And that is where the lethality lies.
Yes, TCAs are highly lethal in overdose. Blocking those cardiac sodium channels causes severe conduction delays, leading to prolonged QT intervals, fatal arrhythmias, and intractable seizures.
It's a terrifying clinical reality. You are diagnosing a patient with profound, paralyzing depression and active suicidal ideation, and then if you use a TCA, you are handing them a bottle of pills that can easily kill them if they take a handful.
This is exactly why clinical guidelines strictly dictate that for high-risk suicidal patients, prescriptions for TCAs must be heavily controlled. You do not give a suicidal patient a 30-day bottle of amitriptyline.
You give them like a week.
You write a prescription for a 1-week supply, forcing them to come back to the clinic, allowing you to continually assess their safety.
Let's talk about the granddaddy of all medication traps, the MAOIs, monoamine oxidase inhibitors, drugs like Phenelzine, phenylcypromine, and the salicyline patch. What is the physiological core of this trap?
It centers around an amino acid called tyramine. Monoamine oxidase is an enzyme found in the brain, but it's also highly concentrated in the liver and the gut. Its job in the gut is to destroy tyramine, which is naturally found in many foods, before it can enter the bloodstream. MAOI medications destroy this enzyme to keep neurotransmitters elevated in the brain, but inadvertently, they also destroy the gut's ability to process tyramine.
And tyramine is found in foods that have been aged, fermented, or cured. Aged cheeses, salami, pepperoni, smoked fish, certain tap beers, and red wines. So what happens if a patient on an oral MAOI eats a pepperoni pizza?
The tyramine is not destroyed in the gut. It floods into the bloodstream, travels to the nervous system, and acts as a false neurotransmitter. It aggressively pushes massive amounts of stored norepinephrine out of the nerve terminals.
And norepinephrine is a vasoconstrictor.
A potent vasoconstrictor. The blood vessels clamp down violently, resulting in a hypertensive crisis.
The blood pressure skyrockets instantly. The symptoms include a sudden, severe occipital headache, pain in the back of the head, nausea, vomiting, hyperpyrexia, and ultimately cerebral hemorrhage. A stroke.
Yeah.
It's a physiological cascade that can kill a patient in an hour just because they ate the wrong cheese.
Exactly. The clinical logic here is that dietary teaching is the absolute, unquestionable nursing priority. The patient must be able to recite the tyramine-free diet. Furthermore, there is a massive interaction risk. If you are switching a patient from an MAOI to an SSRI, or vice versa, you cannot just stop one on Friday and start the other on Saturday.
Because the enzyme takes time to regenerate.
Right. You need a strict 5 to 6 week washout period where the patient takes neither drug. If both are in the system simultaneously, the serotonin levels will skyrocket, triggering the fatal serotonin syndrome we just discussed.
Wow, so you have to be incredibly careful. Let's look at something on the cutting edge. The atypical antidepressants, specifically esketamine, sold under the brand name Spravato. This is an intranasal spray, and I find this fascinating because of how heavily regulated it is.
It is a remarkable development for treatment-resistant depression, particularly because it can reduce suicidal ideation rapidly in hours rather than weeks.
Hours? That's amazing.
It is, but it comes with immense safety red flags. It is a derivative of ketamine, making it a Schedule III controlled substance with high potential for abuse and severe side effects.
The guidelines detail a mandatory REMS protocol, risk evaluation, and mitigation strategy. The patient absolutely cannot take this nasal spray home and keep it in their medicine cabinet.
Absolutely not. They must self-administer the spray under the direct, unbroken supervision of a healthcare provider in a specially certified clinic. And once they take it, they cannot just walk out to their car.
What do they do?
They must be continuously monitored in the clinic for at least 2 hours post-administration.
Because of the dissociation.
Yes. The risks of severe dissociation, feeling detached from reality or one's own body, profound sedation, elevated blood pressure, and a feeling of being heavily intoxicated are incredibly high.
So you have to watch them.
The clinic controls the environment to prevent falls or acute panic, and obviously they cannot drive themselves home. They must have an escort.
Okay, let's pivot to mood stabilizers, starting with the undisputed king, lithium. We mentioned earlier that it's a salt.
Lithium is an elemental metal, a salt that competes directly with sodium in the body for cellular receptor sites. It is highly effective at stabilizing the electrical activity of the brain to prevent mania, but its therapeutic window is microscopic.
Microscopic. The maintenance therapeutic range is just 0.5 to 1.0 LQL, and toxicity starts hitting the moment you creep above 1.5.
Right. If the blood level hits 1.5, you start seeing early signs of toxicity. Severe nausea, vomiting, diarrhea, fine hand tremors worsening to coarse tremors, ataxia, and slurred speech.
The patient looks drunk.
Exactly. If you hit 2.0 to 3.0, you are looking at blurred vision, massive confusion, and the kidneys failing to concentrate urine, leading to massive outputs of dilute urine. Above 3.0, you cross into cardiovascular collapse, intractable seizures, coma, and death.
I always visualize the physiology of lithium as a chemical seesaw located inside the kidneys. On one side of the seesaw, you have lithium, and on the other side, you have sodium and water.
I love that analogy.
The kidney struggles to tell the difference between lithium ions and sodium ions. If a patient sweats profusely running a marathon in the summer, or gets the stomach flu and has severe diarrhea, their body loses sodium and water. The kidney panics and says, "We are dehydrated. Hold on to all the salt."
Because it can't tell the difference. It hoards the lithium.
Right. The lithium side of the seesaw crashes to the ground and the blood concentration spikes into lethal toxicity.
That is a flawless physiological visualization. Dehydration or hyponatremia causes lithium retention and toxicity. Conversely, if a patient suddenly decides to go on a high-salt diet, eating bags of potato chips or drinks gallons of water, the kidneys flush out the excess sodium and excrete the lithium right along with it.
And then the blood level drops below the therapeutic range, and the patient suffers a breakthrough manic episode.
Exactly, which leads to a classic counterintuitive piece of nursing logic. Do not restrict salt for a patient on lithium.
Do not restrict it.
If you see an exam question or a clinical order putting a lithium patient on a low-sodium cardiac diet, you flag it immediately. They must maintain a consistent salt intake and a consistent fluid intake, approximately 2 to 3 liters of water daily. The key word is consistency. Consistency prevents toxicity.
Got it. What about the other mood stabilizers, the anticonvulsants? When lithium fails or is contraindicated, we use drugs originally designed for seizures like valproic acid, carbamazepine, and lamotrigine.
These are highly effective for bipolar disorder, but they have their own organ-specific monitoring rules. Valproic acid is metabolized heavily by the liver. It requires baseline and ongoing monitoring of liver function tests due to the risk of hepatotoxicity. It can also cause a buildup of serum ammonia, leading to confusion and encephalopathy.
And carbamazepine.
Carbamazepine carries a significant black box risk of a granulocytosis.
Let's explain that mechanism because that's a big, terrifying word. A granulocytosis.
It means the drug is acting as a toxin to the bone marrow, severely suppressing the production of white blood cells, specifically neutrophils. Without neutrophils, the patient has no immune system.
So you have to monitor labs constantly.
You must monitor their complete blood count, their CBC, carefully. If a patient on carbamazepine comes to the clinic complaining of a mild sore throat and a low-grade fever, it is a medical emergency.
Wait, really? A sore throat is an emergency?
Yes, because what would normally be a minor cold could be a lethal, overwhelming infection because their white blood cell count has crashed to 0.
Wow. Let's discuss one more biological treatment that isn't a drug. Electroconvulsive therapy, or ECT. I'll admit, when I first started studying psychiatry, my thought was, why in the world are we still electrically shocking the brain in the modern era?
A lot of people think that.
It evokes images from One Flew Over the Cuckoo's Nest. It sounds archaic and honestly barbaric.
It suffers from a terrible historical stigma. born from an era when it was used without anesthesia or muscle relaxants, leading to horrific injuries. But modern ECT is safe, humane, and arguably the most rapidly effective treatment we have for severe mental illness.
So when do we actually use it?
We utilize it for very specific high-risk populations. For instance, pregnant patients experiencing severe psychotic depression. Many psychiatric medications cross the placenta and carry teratogenic risks to the fetus. ECT does not harm the fetus.
Or the actively, acutely suicidal patient.
Exactly. If a patient is actively trying to kill themselves on the inpatient unit, we cannot wait the 4 to 6 weeks it takes for an SSRI to reach peak efficacy in the brain. They might not survive the wait. We need a rapid, aggressive response, and ECT often provides significant relief within just a few treatments.
Who else gets EC2?
It's also utilized for older adults who are so frail they cannot tolerate the cardiac or anticholinergic side effects of high-dose medications.
How does the procedure actually work now in terms of nursing interventions? The guidelines frame the PrEP as being identical to any minor outpatient surgery.
The patient is made NPO nothing by mouth after midnight to prevent aspiration. The nurse ensures the patient voids before the procedure to prevent incontinence during the seizure.
And then in the treatment room?
In the treatment room, an anesthesiologist administers a short-acting intravenous anesthetic like methotrexate or propofol so the patient's completely asleep. And crucially, they administer a paralyzing muscle relaxant, typically succinylcholine.
Succinylcholine is a depolarizing neuromuscular blocker. It paralyzes every skeletal muscle in the body. Why do we need to paralyze them?
Because the electrical impulse delivered through the scalp electrodes is designed to trigger a brief, generalized grand mal seizure in the brain. We believe this massive electrical discharge forces rapid reset of the neurotransmitter systems, flooding the brain with serotonin, dopamine, and norepinephrine.
But their body isn't thrashing around.
But because of the succinylcholine, the physical body does not violently convulse. The only visible sign of the seizure might be a slight twitching of the toes or a change in heart rate.
So it's much safer now.
The physician monitors the seizure duration via an EEG monitor. The paralysis prevents the bone breaks, spinal fractures, and torn muscles that characterize the barbaric ECT of the 1950s.
And what does post-ECT nursing care look like?
Because the patient just had an artificial seizure and received general anesthesia, they will wake up in a post-anesthesia care unit. The immediate nursing priority is physiological. Monitor the airway, provide supplemental oxygen, and check for the return of the gag reflex before offering any fluids.
And once they're physically stable?
Once they're physiologically stable, you manage the primary psychological side effect, which is short-term memory loss and mild to moderate confusion upon waking. You provide frequent, gentle reorientation. John, you are in the hospital. You just had your treatment. It is Tuesday morning.
It's fascinating how refined and precise it has become. All right, this brings us to our final major segment, psychiatric emergencies and legal ethical nursing concepts. We are stepping into the most high-stakes territory a clinician can face.
This is where clinical judgment is tested to its absolute breaking limit.
We talked earlier about the necessity of asking directly about suicidal ideation. But if a patient answers yes, the assessment doesn't stop there. We have to assess suicide lethality.
Right. You need to know how close they are to acting on it.
The guidelines break down specific escalating questions a nurse must ask to determine how close the patient is to the edge.
You are evaluating the SLAP criteria: specificity, lethality, availability, and proximity. You ask, do you have a specific plan? Is the method you chose highly lethal? Are the means available to you right now? Have you made concrete preparations like writing a will, updating life insurance, or giving away prized possessions? And is there a specific chosen date, perhaps an anniversary of a loss?
So, to compare two clinical presentations, patient A says they plan to overdose on over-the-counter Tylenol someday when things get too hard. Patient B says they plan to use a loaded shotgun they currently have stored in the trunk of their car out in the hospital parking lot, and they plan to do it tonight because it's the anniversary of their spouse's death.
The lethality difference is staggering. Patient A requires intervention, therapy, and safety planning. Patient B is presenting a highly lethal, immediately available, specific, and timed plan. That is an absolute psychiatric emergency requiring immediate drastic intervention. They cannot leave the facility.
So what are the immediate nursing priorities when you have identified a highly suicidal patient?
Priority 1 is establishing an unconditionally safe environment. You must physically strip the environment of anything that could be used as a ligature or a weapon. Remove sharp objects, glass, shoelaces, belts, suspenders, lighters, and even clothing with drawstrings.
And then initiate one-to-one continuous supervision.
Constant, unbroken visual contact. A nurse or designated staff member must be within arm's reach, a maximum of 2 to 3 feet away at all times. And yes, that explicitly includes when the patient is using the toilet or taking a shower. There are 0 exceptions. Privacy is completely suspended in the name of preserving life.
This requires a massive, uncomfortable shift in how the nurse interacts with the patient. Throughout nursing school, we are taught to be collaborative, you know? We want the patient involved in their care. We advocate for their autonomy.
But the guidelines point out that in a suicide crisis, the nurse must completely drop the collaborative approach.
It's hard to do that.
It is, but you must seamlessly assume an authoritative role. The patient's physical safety entirely supersedes their desire for privacy, autonomy, or comfort. A suicidal patient might say, "Please, I am so overwhelmed. I just want to sit in my room alone with the door closed for 5 minutes to think. I promise I won't do anything."
And the nurse's instinct is to show empathy and give them space. But the nurse has to say no.
You must say no. You use a firm, matter-of-fact tone. You are not allowed to be alone in your room right now. My primary job is to keep you safe, and I will be staying right here with you. It is entirely non-negotiable.
Let's explore the legal and ethical boundaries of this, because the guidelines touch on an incredibly complex, evolving issue. Medical aid in dying or assisted suicide. The text notes that currently 10 U.S. states permit some form of physician-assisted death for terminally ill patients.
It is a profound, deeply personal ethical debate that touches on autonomy, suffering, and the core purpose of medicine. But for the nurse facing this topic on an exam or navigating it in practice, you must clearly understand your specific legal and ethical boundaries as defined by the nursing scope of practice.
Which is exactly where's the line drawn for the nurse?
The American Nurses Association is clear. It is not the nurse's role to legally facilitate the act of ending a life. You do not administer the lethal medication. However, your ethical duty does not end just because a patient chooses this legally sanctioned path. The nurse's role is to provide unwavering, non-judgmental supportive care to the patient and the family as they navigate these profound emotional and physical decisions. You manage their pain, you provide presence, and you do not abandon them.
And regarding patient rights versus safety in a standard inpatient psychiatric setting, we are drilled constantly on the concept of the least restrictive environment. Patients have the right to wear their own clothes, have visitors, and move freely.
Patients absolutely retain their civil rights when they are admitted to a psychiatric facility. They don't lose their humanity at the door. However, there's one fundamental legal exception to the least restrictive environment rule.
Imminent danger.
Exactly. If a patient is an active assessed danger to themselves or others, that acute safety mandate completely overrides their right to privacy or freedom of movement. That is why one-to-one supervision, confiscating personal belongings, and in extreme cases, utilizing physical restraints or seclusion are legally and ethically justified.
It's a temporary suspension of autonomy for the explicit purpose of preserving the life so they can eventually regain that autonomy.
Precisely. You restrict them today so they can survive to be free tomorrow.
Wow. We have covered an immense amount of ground, from the cellular mechanisms of serotonin to the legal frameworks of involuntary holds. Let's bring this all together for the big takeaway. For the listener prepping for their boards or heading into a grueling 12-hour behavioral health shift, the 80-20 rule boils down to this. Safety is the ultimate, uncompromising priority, and that safety is achieved through profound, educated vigilance.
Whether you are creatively feeding a manic patient a high-protein sandwich while they pace the hallway, whether you are closely monitoring a deeply depressed patient who suddenly has a burst of physical energy from their new SSRI, or whether you are strictly policing the fluid and salt intake of a patient on lithium to prevent lethal kidney toxicity, you are constantly managing the razor's edge of psychiatric interventions.
It's not just knowing the disease symptoms, it's mastering the environment and anticipating the traps within the treatments. But I want to end on a final, provocative thought pulled straight from the self-awareness section of the clinical guidelines. We talk a lot about the patient's mind, but what about the nurse's mind?
This is perhaps the hardest, most humbling lesson of all in psychiatric nursing. The concept of countertransference.
How will you, the nurse, handle your own emotional and psychological response to these extreme behaviors? Think about it. When a manic patient repeatedly violates your personal boundaries, insults your intelligence, screams at you, and completely depletes your physical energy over a 12-hour shift.
It takes a toll.
Or when a suicidal patient rejects every single empathetic attempt you make to help them, staring blankly at the wall, making you feel entirely incompetent and useless.
The clinical texts offer a stark warning here. Nurses are human. If we're not highly self-aware, we will unconsciously start to avoid the patients who make us feel incompetent, exhausted, or afraid. This is empathy fatigue.
It's the subtle, dangerous behavioral shifts. Can you recognize your own frustration and anxiety? Can you realize that you are intentionally walking slower to room 4 or finding excuses to organize the supply closet because the patient's profound, heavy despair makes you feel helpless?
The true elite mastery of psychiatric nursing isn't just memorizing drug half-lives, tyramine diets, or the Hamilton Depression Rating Scale. It is mastering your own self-awareness.
Yeah.
It's constantly monitoring your own emotional pulse so you don't unconsciously abandon the complex, difficult patients who need your therapeutic presence the most.
To circle all the way back to where we started this deep dive, you can't just look at a clean black and white x-ray and fix the broken bone. You have to willingly step into the murky, muddy, unpredictable waters of human emotion. You have to sit in the heavy silence, absorb the discomfort, and offer yourself as the steady bridge back to reality.
And that willingness to sit in the dark with someone until they find the light is exactly what makes psychiatric nursing such a profound, life-saving calling.
Thank you for joining us on this critical deep dive. We wish you the absolute best of luck on your board exams and, more importantly, on your journey into clinical practice. You've got this. Keep yourselves and your patients safe.